Welcome back to PIC Unit discussing pulmonary hypertension. The general flow for our talk today will be the definition of pulmonary hypertension, some of the risk factors that predispose patients to it. We will then kind of go into the physiology of normal pulmonary vasculature, how it's supposed to respond, what different factors affect it, and then we'll dive right into pulmonary hypertension management strategies. Now, when we start with this, we should really get a grasp of what some of the normal values are supposed to be. When we look at normal systemic blood pressure, of course, in adults, these are numbers that range between 100 and 140 over 60 to 90. But the pulmonary system itself is a low pressure system where the pressures really range 15 to 30 and 8 to 15. So when we talk about the diagnosis for pulmonary hypertension, we really tend more to look at the mean pulmonary arterial pressure, and pressures that are higher than 20 and definitely higher than 25 classify a patient for pulmonary hypertension. Now, the tricky thing for this is that pediatric patients have age-dependent pressures, and even though their pressures may be elevated by this definition, it may be normal for their physiology. And what I mean for that is basically the pulmonary pressures based off of age. Now, when a baby is born, they're naturally born with higher pulmonary arterial pressures, and this reflects in utero circulation, where there isn't much blood going through pulmonary vasculature at all. Once the baby's born, there's a number of changes that start taking place in terms of different circulations, and this pulmonary arterial pressure does decrease over time. And as you can tell through the graphs right here, pulmonary blood flow increases with birth, but pulmonary vascular resistance doesn't actually attain normal values until multiple weeks after birth. Now, normal pulmonary vasculature has a number of factors that can affect it. Things that can increase pulmonary vascular resistance are low fraction of inspired oxygen or hypoxemic conditions, high PaCO2 or times of hypoventilation, states of acidosis, specifically metabolic acidosis, agitation and pain, and high hematocrit. Things that can decrease pulmonary vascular resistance are a high fraction of inspired oxygen, low arterial CO2s or hyperventilation, states of alkalosis, and also if the patient is well sedated or muscle relaxed. Adjunctive agents can also decrease PVR, such as nitric oxide and vasopressin as well. And then you'll see at the very bottom, positive pressure and expiratory lung volume can play into it, but they can really go either way. If you put a tremendous amount of pressure inside the chest, which is basically invasive positive pressure ventilation, you do naturally increase PVR, but then there's also an interplay that exists with what the patient's actual lung volumes are, and that's what we'll dive into next here. So if we take a look at lung volume, on the lower end of the lung volume, you'll notice that this black line here represents total pulmonary vascular resistance. You'll notice that PVR is actually high even when the lung volume is when the lung volume is low. But even if we go to higher lung, so kind of going into it, there's a lot that plays into both pulmonary arterial pressures as well as pulmonary vascular resistance. And there's a great paper here that kind of goes over the consensus statements for diagnosis and treatment of pulmonary hypertension. So if you want to go to this paper, it's a great review paper to read. But you can tell there's a tremendous amount that goes into it, so it is polyfactorial. Now, when we look at management strategies, there's a lot that has to really be incorporated into this, but the most basic strategy we can use is oxygen. Oxygen is a very potent pulmonary vascular vasodilator, and that's always the first option that we go to. Other treatment strategies, including states of alkalosis, sedation, and neuromuscular blockade, can also be used. And kind of tying into the previous slides where we talked about getting the right lung volume. And this doesn't mean areas of atelectasis, this does not mean areas of hyperinflation, but really times of best compliance is where you're going to have the best pulmonary vascular resistance. One other mention that we need to kind of talk about is fluid strategies. So especially in neonates, the RV is incredibly preload dependent, and so any degree of volume loss is poorly tolerated. So patients that are undergoing pulmonary hypertensive crises, sometimes it is worthwhile to do a fluid bolus on them. Additional strategies include these adjunctive agents such as inhaled nitric oxide, sildenafil, and milrinone as well. And then we can start branching into the other agents, which again is dependent on where you are regionally. However, in our institution, we do use epoprostenol, and then you can flex into bosentan as well. But really, pulmonary hypertension is a very complex topic to talk about, and there are a lot of breakthroughs that are coming through with it as well. So it's just a matter of trying to keep up with recognizing it, and then also finding the different arms of treatment. As always, thank you so much for listening to our talk on pulmonary hypertension. We welcome any questions on the topic, and hit subscribe and like on our video. Thank you.